Hello, and welcome to another episode of Improve Healthcare, the show that focuses on ideas and insights to improve the healthcare delivery continuum around policies, processes, and patients. I'm your host, Rich Greenhill. For this episode, we will focus on high reliability organization with an international expert, my colleague, Mr. Stephen Powell. Stephen Powell is the Chief Executive Officer and founder of Synensys, a professional services company headquartered in Peachtree City, Georgia. Steve is a recognized leader in performance improvement, having led programs in the United States Navy, the commercial airline industry, and the healthcare industry for more than 30 years. His most recent experience includes patient safety, quality, and patient-centered care improvements, health systems strengthening, learning systems, high reliability, care coordination, value-based initiatives, and team training. He has authored numerous articles on human-centered design, reflective learning, teamwork, global health, safety, change management, communication, quality improvement, patient experience, and patient safety culture. His book, The Patient Survival Handbook, Avoid Being the Next Victim of Medical Error, is a call to action for deeper patient engagement and activation for patient safety, increased effectiveness, and quality improvement. Steve is currently a doctoral candidate in health administration at Central Michigan University. Steve is a member of the Human Factors and Ergonomics Society, the Society of Industrial and Organizational Psychologists, the Clinical Human Factors Group, and the American College of Healthcare Executives. A warm welcome, Steve. How are you today?
Hey, Rich. Thanks for having me.
So first, as a fellow Navy veteran, I just want to thank you for serving. I know that a lot of us that served are, we don't join for that reason, but I just want to honor you and thank you for your service as a pilot in the Navy.
And being fellow Navy, I'm right back at you. Thank you.
Thank you. So your background is really intriguing, and would you share a little bit about the intersection between being a 777 pilot and how this has informed your interest in healthcare?
Thanks, Rich. Yeah, I think I wrote a little bit about it in the book, The Patient Survival Handbook. But the story, the intersection point for me was after having a pretty successful career in safety and quality work in both the military and in commercial aviation. My father was diagnosed with cancer. And during the process of him receiving treatment for that, I was there, as an advocate for him during that treatment process. And he suffered a medical error. And as we'll talk about a little bit, about 50% of medical errors are deemed to be preventable medical errors. So these are things that we can keep from happening. And from his standpoint, it led to his untimely death. He was a young man when this occurred. And again, it was kind of a call to action to me, is that some of the same safety principles and practices that we had practiced either from a military perspective or as a pilot in the commercial aviation side were not being followed. These practices weren't being followed by, healthcare providers or at the bedside or even within the systems of what we believe to be a healthcare system. And whether it be information or technology or people, that the same types of practices weren't being used or leveraged for prevention of harm. And so again, that was kind of the intersection. And just the question for me at that point was, so what could I do about it? I was in the middle of my graduate work in human factors, and it just was a natural for me in that call to sort of think about the opportunity I had to kind of leverage what I had learned up to that point, and then see how some of that might translate into the healthcare environment.
Wow, that's really a great story, Steve. Sorry about that. I think a lot of that, what you described about, him being harmed is what drives me in healthcare as well, safety and quality, because, we can do better. And you and I both know that. And that's why we're in this. So thank you for sharing that very, very personal and touching story. What do you think we are today related to the state of patient safety in globally or nationally or both?
Well, I think what I would say is we're probably, if you take I'll take a world football analogy, a soccer analogy, is we're probably still early in the first half of the game. on patient safety, and that is after really a 20-year, I think a good 20-year journey, because most people are aware of the TARES Human Report, which really became the seminal work on patient safety, and it really was a catalyst for me personally in early on in my career in patient safety to better understand the challenges that healthcare was facing and trying to be a safer domain, a safer place, and more highly reliable, as we'll talk about in the HRO kind of world. And these were, when I look back, I would say we're still quite a bit behind other high risk industries like aviation, nuclear power, military. We're quite a bit behind those other sectors that have been at this a little longer. So I think we're early on, but I think there's a lot of progress being made, and not only that, I think there's an awareness of patient safety that potentially 20 years ago just wasn't there, and that's a result of our ability to capture harm data more accurately than we have in the past. And so we can talk a little bit more about that. But I think that we understand maybe the problem a little bit more. I'm not sure that we've completely decided that it's a problem that is first and foremost on every health system's priority list of things that they have to do today to in fact keep a patient safer in their facility.
Those are good points. One of the things I often encounter in my work in quality, and in my last role as a quality chief, I mean, people understand quality and they understand patient safety, but they also look at me and say, okay, that's Rich's issue because he's the chief of quality, right? He's the quality versus we all have a stake in it. And you're right. I think there's not that urgency yet. And so that's going to be the thing that really gets us going. So let's talk a little bit about one of your areas of expertise, high reliability. So talk us through, what is high reliability and what are the principles? I mean, there's a lot of hype out there about it. What about it, about what it is and what it isn't? Would you tell us your perspectives there, if you would?
So high reliability has its origins in a couple of different fields, but if you go back, I'll just kind of tell a story that is more around the idea of how high reliability and how it works in our world where we used to work and live, which would be in the U.S. Navy is a good example. And what White and Sutcliffe were kind of first authors on some of the work that came out in the early 1990s on this, and the idea is that you would go on board an aircraft carrier. And I spent a lot of time I was a Navy pilot, before becoming a commercial pilot. And the idea is you spend a lot of time on an aircraft carrier. It's a very dangerous place. Inherently, so many bad things can go wrong on the carrier. What's really interesting, when you're in the midst of it as a young pilot and out there doing what you do, and you're trained really well to be safe and to be operationally effective, in your work. And that was one of the real keys to that environment being safe. The bottom line is that the researchers looked at this environment, and the other thing that they saw was that it was safe, and it was safe even when the risk was so high. Imagine recovering an aircraft onto a landing platform that's not much longer than a football field, and so that kind of thing, and doing it at night, during the day, during bad weather, good weather, it didn't matter, and they did it. And then the folks that were responsible for bringing that aircraft aboard and making sure it was safe, the average age of those young men and women was 19 years old. And so the idea is, how were these sailors and airmen able to successfully keep an operation safe, and their skill sets? What were the skills and the way that they operated that allowed that operation to be so safe, even though it was of such high risk activity? And that was kind of the side. And what they learned was there were really 5 principles that came out of that work, and they've been carrying through to high reliability organizations across industries. First one is preoccupation with failure. And what a preoccupation with failure is that what they learned was that these sailors, they constantly find ways to identify areas that can be improved. So are always looking for ways to improve their work. And I think if you looked at that in healthcare, it would be that do we, like you said, do we understand that improving our work is part of our work? That's the question that quality or safety officers might ask of a frontline provider. Do we understand that improving our work is part of our work? And then there's this reluctance to simplify. And this is going to go back to that, the build and the leveraging of connections to solve problems. And that reluctance to simplify is really in our systems thinking. You and I, we've go way back into the idea of the power of systems work and systems approach and systems thinking. And HROs or high reliability organizations, they really embrace this. So do the people. They see the connections between the person who taxis the aircraft up to the catapult, the person that's involved with ensuring that the catapult operates properly, the person who's up in the air traffic control tower that helps to guide and direct the aircraft, and even the ship, that they're positioned correctly so that they land into the wind and the ship's positioned in the proper place to manage the sea states and others. So there's a lot of connections that go into that. The other thing is that these folks and HROs, they're sensitive to operations, meaning that across the board you empower your colleagues to identify potential system failures. So idea is that you can speak up, anyone, no matter how junior you are, you can speak up and you can bring a safety concern to a supervisor or a department head or an authority, and that they will do something about it. And that's really the key, that it's not just that I'm telling someone and they're not going to do anything about it. There's also a deference to expertise. I love this one because it's so appropriate. If you can kind of put your mind on, if you ever take a look at any aircraft carrier, the surface of that deck, and there's these people in green shirts and people in yellow shirts and people in red shirts, and they all have a role to play on that carrier deck. And so the idea, though, is that I, as a pilot, they look at me, oh, wow, this is the pilot. He's going to get in the airplane and he's going to go fly it. So he must be, more qualified than me. But for me, they probably think that's the scariest place to be, is inside that cockpit. And in fact, the scariest place to be is walking out to the airplane on the catapult, because it's so dangerous out there. And if I was to enter a safety zone, no matter the fact that I may outrank someone, that young airman would be the first one to maybe pull me aside to make sure that I'm not in the way of a jet blast over there. That's that deference to expertise. On that carrier deck, that green shirt, that yellow shirt, that red shirt, they have more expertise than I do as a pilot, even though I might have the rank or the knowledge or even a position of influence there. And then finally, there's this really overall concept of really continuous performance improvement mindset, a culture of safety, and finally this trust that you develop for this kind of reporting culture that you're trying to develop as well. And that at top of the list here is, and we all know this because we're taught it from the get-go, is leadership, and leadership to drive high reliability towards this idea that we have is a goal of high reliability or end state, which is reduce preventable harm. And that harm could be to personnel. It could be damage to material. It is, in essence, this search towards zero. And in the healthcare space, it's really this belief that we're going to eradicate preventable patient harm. That's the ultimate goal.
That's great. Steve, you brought back a lot of great memories. And I'll tell you that the one thing that resonated with me, what you said, and thinking about my experience coming in the Navy, is we are all taught as officers, enlisted, whatever, when we first come in, about the training timeout. And that is the flag you throw down, regardless of your rank, who you are. And that is respected and honored throughout the service, whether you're Marines, Navy, because I served with both. And in my blog on my website, I wrote a little bit about that was my thing that sort of resonated with me, that it doesn't matter if you're the E1 and you just came in and you see Captain Powell getting in his airplane and he's about to get gobbled up by one that's landing. You go grab him, and Captain Powell's not going to get mad at you and speak ill to you because you saved his life, and he's going to trust that you were doing the right thing. So it's like you said, leadership, and it's really about the culture that's set forth. So that's really great. thinking about high reliability and what you just mentioned for us, what are some of the barriers you think, you know, are there to adopting high reliability? I mean, it seems like we've been talking about it in healthcare, but we haven't done it exactly yet.
Well, there's two. I think it, in any change of, so it's a change of behaviors, right? And so we have to think differently, before we can act differently. And others will say, I had a real great mentor that once I said, sometimes you just need to act your way towards a new way of thinking. And in this way, it kind of works both ways, top down, bottom up sort of change. And that is, again, I think some of the things you just mentioned, you have to empower folks, no matter if they're junior, senior, whether they're a doctor, a nurse, a technician, a lab personnel, anybody, right? Administrator, or a, anyone, a vendor. So they have to be empowered. So I think that's that, like you said, that culture. So your culture can be a barrier. That could be one thing that's a barrier. The first and foremost is this, even the concept, even me saying that preventably we could get to zero, that possibly we could get to zero preventable harm can be a barrier to some people. They just don't think it's possible. And so if you don't think something's possible, you may never pursue it. And so it is a little bit of a journey, and there is a little bit of a leap that you take, and you're taking evidence that's been translated from other industries potentially, and then adapting and adopting it within your context. It has to be contextually relevant. So I could tell you something that works in the cockpit or on the flight deck, but we have to be very thoughtful about how we tailor that to the healthcare setting. And that could be inpatient, outpatient, a lab. It's really going to be different. And it really has to be thought through differently. The other side, I think, is there's an investment by leaders. There truly is. And this is not a one and done type of journey. And so if it is kind of thought through as the initiative of the month or flavor of the month type of thinking, it won't work. It takes a little longer for you to achieve this, but you will see that the changes can happen actually pretty quickly as far as the reductions in actual harm. We see it all the time, and I think at the individual level, whether you're an individual provider or a staff member, support person, is this idea of or leader. Is there are two elements to making change that are important in this. And one is skill. So you have to understand how to do these principles, these new behaviors potentially. So there are tools that go along with this. There are, like you said, this training that you receive in this, and taking that time out for that kind of skill building is not always available in busy healthcare environments, especially in the environment we find ourselves today. And that's one. And then the other one is really a will issue, which is, is it a will issue of leaders at all levels of the organization that we will do this, and it's within our will to reduce patient harm? It's skill and will.
That's good points. I wonder, as we emerge from and recover from COVID, how you think that HRO principles could help us. Is this the perfect moment to say that we're emerging from a 100-year pandemic? Is this the moment? And if so, what could we do?
It really is, Rich. I think there's more. I'm getting more response now from this thinking about what would it take for us to be a high reliability organization, and what would it mean if we were. And I guess the biggest thing that I would see where we've been the last year is that we have definitely been in a reactive mode. And what high reliability is puts you on a safety footing or an operational footing that is proactive. You're in a much different footing or setting or capability than you are when you're trying to react to things. When you're reacting to things, there is a lot of uncertainty. There's a lot of build-up time that it takes to become better at doing something. In high reliability organizations, they would have really already thought through what would they do if this happens and when this happens. And so there's quite a bit of that sort of ability to plan. The other side of it is it's not just about getting, a set of policies, plans, protocols, and procedures in place, which are part of safety and quality, are standards. And we all know those exist in healthcare. But there's another side to safety and high reliability, and it's really in this ability to adapt, our adaptive capability. And that makes us much more nimble to respond to things like we've seen with the pandemic. And being able, that's what mostly organizations have had to do, really at a gut-wrenching level in some ways, to improvise using something like a debriefing technique that was used quite actively in the military. Sometimes they were known as the after-action report. These things are very quick, rapid cycle improvement cycles that had to be done at the end of a shift, that had to be done at the end of the day, because we had to switch the whole operation to get ready for the next day based on some emerging conditions. That's the kind of flexible nature of a culture that is moving towards high reliability. And I think a lot of leaders believe that we're not out of this. And even when we are, will we ever go back to being only reactive and having safety programs that are reactive in nature? Once a patient's harmed, we do a root cause analysis and we try to figure out that doesn't happen anymore. What about if we collected safety data all the time, continuously, and we're able to see signals of system degradation or places where our system's not operating properly, like where potentially where our next infection might come from, and how that might be able to spread throughout our hospital. So these are kinds of different new ways of thinking that would come from being on a high reliability journey.
What I heard you say was being nimble and being able to adapt quickly. And I'm thinking back about the firefighting training I went through. We went through training about what if a plane crashed. We went through that whole thing over and over. We went through what happened if a ship caught on fire, right? Over and over, how you react. And so at one point, we thought we were under attack in a certain part of the world, and we practiced all the time for something called general quarters. I'm sure you know what that is. Where, for our listeners, that's where you shut the ship down and get into a battle posture. Well, we practiced, and we never could reach 7 minutes, which was the target for our inspectors. Well, one day it happened where the chemical alarm went off, and we had the ship shut down in less than a minute because we had practiced doing that over and over and over. And so to your point, it's, by the time something happens, you should already kind of know how you'd react, and your people should be prepped to think about, those reactions. So great points.
Well, one of the things that, just to follow up with what you shared, that truly was, I think another finding was that this rehearsal training or simulations, like you just described, when we apply that, of course, everybody's familiar with the pilots in the simulator or, drills like you're talking about. But when you apply that to maybe an obstetric emergency setting where you can simulate, a postpartum hemorrhage, how would the team move from, a delivery cycle to an operating room environment? And it just really is, until you faced a postpartum hemorrhage, you can't imagine how critical it is to get the patient and the baby managed in such a quick way so that loss of life doesn't occur. So the principles can really, another principle that can be applied regularly, and that is simulation.
That's great. That's really great. So as we get ready to wrap up here, first, do you think high reliability is simply another safety program? Why or why not?
Well, I think it's more than that, because if you think about the intersection that we're at with this programming, it's not just about safety, okay, and safety meaning the reduction or absence of harm, right? It's about operational effectiveness, is what we're talking about. It's about our response time. It's about reducing risk across the organization, risk to patients, but also risk to staff. I think another one is the resilience nature. That's one thing I didn't bring back up, Rich, but I think it's really important to highlight. Is one of the final principles is that commitment to resilience of high reliability organizations. That's that ability to bounce back and quickly cope with adverse events as well. Learn from mistakes. And that is going to be really important as we think about coming out of this post-pandemic phase of we've got a truly a workforce problem that's going to be faced by all organizations about how will we regain resiliency or within our workforce across our system to get it functioning again, and that's going to be a really big part. So I think there is that part of high reliability is more than just a safety program. It's really it's a patient engagement platform. It's a quality, safety, risk. It's an operational excellence program. Things like Baldrige and other awards. It aligns well with some of this other thinking that we've had for years in healthcare, but that we didn't have an umbrella sort of overall vision setting or vision casting about where we could all be if we were able to do this. Ultimately, it will be about even our own health provider resilience that we would bring up around this whole idea, because it's energizing. And what you were talking about, you were able to accomplish that drill timing and that feat through the work of a very, very high reliability team. And that to me is a really important part of what makes HROs. They're not made by one leader or a set of leaders. They're made by high reliability teams and teams of teams that do that. So I think that what you're seeing here is that high reliability can be the umbrella for an organization that works, highly effectively and highly efficiently at the same time.
That's really great. Such a timely topic today. Steve, you've taken us through some areas that are important to ponder for high reliability. I want to encourage our listeners to learn more about Steve and some of the work he's doing, he and his team at Synensys at synensysglobal.com. And I want to thank you, Steve, for taking time out of your very busy schedule to be here today.
Thank you, Rich. I really appreciate being here. It's always a pleasure to speak with you and to learn from you as well.
All right. Thank you, Steve. Take care, and we'll see you soon.
Thank you.